and welcome to this very special item in our series we call Expert Briefings. The first time we've actually tackled this subject at the PDF, the subject of vision symptoms of Parkinson's disease, which we've entitled More Than Meets the Eye. I'm delighted to say that we have an outsized audience for this particular seminar, which shows how important it is to cover every piece of the Parkinson's landscape, and we're delighted to have all of you here joining us. Thank you very much, and I hope you enjoy this as much as certainly we plan to at PDF in New York. Before I introduce our special speaker, I'd like to just a couple of credits for the occasion. First of all, we're joined, as we have been now for a couple of years, by several eminent regional Parkinson's organizations, the Houston Parkinson's Society, the Michigan Parkinson Foundation, Parkinson Association of the Rockies, and the Parkinson Association of the Carolinas. These are all independent Parkinson's groups, which PDF enjoys a very fine networking relationship with, and we're delighted to have them as co-sponsors of this series. I also want to thank very seriously and fulsomely our sponsor for the series, the AbbVie Corporation. AbbVie has a new entry into Parkinson's treatments approved by the FDA very recently, and we're delighted to have them as our sponsor for this series. Needless to say, they have nothing to do with the editorial content. That's entirely the work of the Parkinson's Disease Foundation, but we could not do this job without the support of our corporate sponsor, and we're very grateful for that. A couple of logistical business things. The PowerPoint slide deck can be downloaded from the reminder email that you should have received this morning, or, if you prefer, from the PDF webpage that highlights this talk. So you have two choices in getting the slide deck later. I also want to mention that for those of you who are our health professional friends who are in the audience, I know there are several of you, maybe more than several, that you are entitled to receive for your attendance at this one-hour session one free continuing education unit through the American Society on Aging. So if you did register as a health professional and you indicated you would like to have CEU credit, you will receive an email by the end of today from us with steps indicated as to how you collect your credit. And then you have 30 days until April 2nd to collect it. So please don't neglect that if you would like to have that extra little dividend from your attendance at this session. Now, it's my great pleasure to introduce our guest speaker, who is an assistant professor of neurology and an assistant professor of ophthalmology at the Johns Hopkins School of Medicine, Dr. Daniel Gold. Dr. Daniel Gold works in the areas of ophthalmology, which I mentioned, Otolaryngology, and he has a DO and specialized in head and neck surgery and neurosurgery at the Johns Hopkins School. We're just delighted to know him and to be welcoming him. And he will be speaking for around 30-40 minutes, which is the way we normally handle these things, leaving the balance of the time we have together for your questions, which you can start emailing to us now. We have two people busy watching the screen and taking them off the screen so that then they can pass them to me, and I will do the questioning once Dr. Gold has finished his talk. So, Dr. Gold, thank you very, very much for regaling us and for joining us on this very, very important topic. The floor is yours, and we all look forward very much to hearing you.
Great. Thanks so much for the introduction and for the invitation as well. So I'm talking about vision in Parkinson's disease. So I'm an assistant professor of neurology, ophthalmology, neurosurgery, and otolaryngology. I'm a neurologist with fellowship training in neuro-ophthalmology. But I also work closely with the departments of neurosurgery and otolaryngology, doing also vestibular disorders. So it's a lot of titles. It's a little confusing, but again, I'm primarily a neurologist, neuro-ophthalmologist. So just to kind of get that out of the way. So first, some important questions and background to sort of get us started before we have the actual talk. So first of all, why should I care about vision? We'll talk about that. Why did I sign up for this webinar in the first place? Who is this guy, and what is a neuro-ophthalmologist, which many patients perhaps have never heard of an ophthalmologist. In the medical community, I would suspect that many physicians aren't sure what a neuro-ophthalmologist does or sees either. And what visual symptoms should I be aware of? So number one, why should I care about my vision? Well, people like their vision. Vision is a very important sense. So about 30% of, when I say supratentorial mass, what do I mean? There we go. So within that blue rectangle, that's essentially the supratentorium. So about 30% of that is solely dedicated to vision, perception of vision, interpretation of vision, from the very basic shapes, sizes, movements to the more complicated interpretations of that information. So it's a very important sense. Because it's so important, much of the brain space is devoted to vision. So why did I sign up for this webinar? A very good question. So as everyone with Parkinson's or folks that take care of Parkinson's knows, there are many motor features of Parkinson's disease, but also many non-motor features. So some of them, the sensory parts, again, I'm not going to go into each in depth. Sensory parts, problems with smell and pain and internal tremors, autonomic problems, sleep disorders are extraordinarily common, as well as neuropsychiatric issues, usually sort of later into the disease course. But also visual symptoms are extraordinarily common in Parkinson's. So why do we care about the visual symptoms? Well, again, they're common, they're bothersome, and many of these are actually quite treatable and fairly easy to diagnose. So number 3, another very important question, who am I? What does a neuro-ophthalmologist do? So how is a neuro-ophthalmologist different than a regular eye doctor? So the 3 O's, so an optician is somebody who essentially prescribes your glasses. This isn't a doctor. An optometrist can do an eye exam, can prescribe glasses as well. I'm sorry, the optician is the person that would actually make the glasses. Optometrist would be somebody that would prescribe glasses, do eye exams. And then there's an ophthalmologist. So an ophthalmologist is somebody who did 4 years of medical school, followed by 4 years of an ophthalmology residency, plus or minus additional fellowship training after that. So that can be an MD or a DO. Myself, I'm a DO. And then neurologists who do, again, 4 years of medical school, 4 years of neurology, and then like myself, a fellowship in neuro-ophthalmology can also do this. So it's a crossover between the eyes and the brain. So in order for, again, we'll talk about the visual system quite a bit. This is demonstrating mainly the motor system, so the eye movement system. So the eye is surrounded by lots of different muscles, lots of different structures, but we need to be able to move the eye to look at things that we want to look at. So there's a lot of very complicated circuitry in the brain to allow the eye to move where we want it to move in different ways. Again, I'm not going to go into that too much, but just making the point that neuro-ophthalmology, it's where the eyes and the brain intersect. Oftentimes, neurologists aren't particularly comfortable with neuro-ophthalmology, and oftentimes ophthalmologists aren't particularly comfortable for it. So we're sort of somewhere in between. So again, vision loss, we'll talk about the vision part of it a little bit more than the eye movement part of it, but we'll talk about both. So what would I see on a daily basis as a neuro-ophthalmologist? So vision loss, not from a problem within the eyeball itself, but perhaps the optic nerve, which is a connection, the cable that connects the eyeball to the brain, and these pathways that go from the eyeball back to the brain for interpretation. Tumors in the eye socket, again, disorders of the eye muscles or nerves that make those muscles of the eyeball move, as we just saw. Something called nystagmus, jiggling eyes, funny eye movements, that all falls within neuro-ophthalmology. Double vision as well, and we'll talk a little bit about double vision specifically today. So what does a neuro-ophthalmologist do? What will we do during a typical examination? So we're looking at the visual pathways, how well the visual information is entering the eyeball and going back to the back part of the brain where it needs to go, as well as the movements of the eye, looking at the pupils. So again, visually, we look at the visual acuity with and without your glasses, looking at color vision. If the color vision is significantly off, sometimes that can imply that there's a problem with the retina or the optic nerve. Visual field testing, sometimes we just have you count fingers in all 4 quadrants, top, bottom, left, right, that kind of thing. And sometimes we do even more formal visual field testing where we put you inside sort of a dome and your chin's on a chin rest and you push a button when you see a light flash. How well or not well the pupil reacts, measuring the eye movements, the position of the eyeball in the socket, sensation of the eyeball itself, sensation of the face, looking at the front part of the eye, looking at the optic nerve in the back of the eye. And again, the optic nerve is a cable that connects the eyeball to the brain, and we'll see some pictures of that. So why do we do all of these tests? So essentially, it helps us to localize where the problem could be. Depending on where the localization is and what the symptoms are, what is the problem? And then from that, generally, how can we help the problem? And there are many treatable things that we can do once something is identified. So what visual symptoms should I be aware of? So essentially, the common things we're going to talk about today in the left column. Uncommon, we're not really going to talk about, and these are all fairly uncommon in Parkinson's disease. There are certainly Parkinson's plus syndromes like progressive supranuclear palsy and other, and those Parkinson's plus syndromes are more likely to have these uncommon features, such as blepharospasm, or sort of involuntary closure and spasm of the eyes, apraxia of eyelid opening, where it's actually just difficult to open the eyes, almost like that behavior of opening the eyes was sort of forgotten. Sometimes, particularly in progressive supranuclear palsy, looking up and looking down can become very difficult. And there also are some other kind of less specific eye movement abnormalities, again, much more common in the Parkinson's plus syndromes, much less common in Parkinson's disease. So now that we got that out of the way and you know who I am and what I do, let's talk about Parkinson's and vision. So the objectives, what I'd like you to come home with today is kind of understand why vision can be affected in Parkinson's, understand the normal interaction between the eyelids and the surface of the eye, the ocular surface, which, believe it or not, is actually quite important in many of the symptoms that a patient with Parkinson's might have. Understand characteristic eye movement abnormalities seen in Parkinson's. Again, we're not going to talk about the uncommon ones, but something very common like convergence insufficiency we will talk about, and I'll talk about what exactly that means. So where might visual symptoms come from? So we're going to talk about central and color vision abnormalities. We're going to talk about blinking and ocular surface abnormalities as well. We're going to talk about some eye movement abnormalities, namely the convergence insufficiency, as I talked about. And then briefly, we'll talk about some others. So hallucinations are fairly common in Parkinson's. And then there are some others which we're going to talk a little bit less about, cataracts. Perhaps there's an association with primary open-angle glaucoma as well. And I'll let you save those discussions for when you see your ophthalmologist. So number one, I wanted to talk about central and color vision abnormalities. So a little bit of neuroanatomy so that you can see these structures that I was talking about. So this is the eyeball. A cross-section, you can see the front part of the eye where it says the cornea and the lens to the left side of the left picture. And then that light needs to travel through the front part of the eye, through that cornea, through that lens, and it needs to get as clearly as possible and as straight as possible back to that red circular area in the back called the fovea. So essentially, all of the structures in the front part of the eye, the purpose of them is to sort of focus the clearest possible image to the back of the eye directly onto the fovea. The fovea is responsible for our best vision. Whatever we're looking at, we're pointing our fovea directly at. And when the fovea in the left eye isn't lined up with the image that the right fovea sees, then you might see two images instead of one. And you can see in the upper right-hand picture the optic nerve as well. So that visual information that initially goes to the fovea needs to go somewhere. And again, that optic nerve is the cable that connects the eyeball to the brain. So it needs that visual information needs to travel from the fovea to the optic nerve. Again, so you can see kind of a couple different views of where the optic nerve is. On the eyeball picture to the left, that blue rectangle surrounding the optic nerve is right there. If you were to look at the brain from above, in the bottom right picture, you can see the optic nerve connecting, again, the eyeball to the brain matter itself. So in the upper right picture, the flow of visual information from the fovea to the optic nerve picture, all of those red structures that are radiating out of the optic nerve are arteries and veins. And all of that sort of orange-pink substance all around is called the retina. So that's the back part of the eye. Again, the best seeing part of the retina is the fovea, and therefore we want to concentrate and focus as much of the visual information on the fovea as possible so that we get the best possible and the clearest image. So it doesn't, if you are unable, or if you have for instance, strokes or something happens to the back part of your brain, that visual information, regardless of whether the eyeball itself is working, regardless of whether the optic nerve is working, that visual information needs to get to the back part of the eye to be interpreted. Without that back part of the brain, the visual information can't be interpreted. And again, if you take out both sides, it's as if you're blind, as if you've lost both of your eyeballs because there's nowhere for that visual information to go. So it's like you're not getting any visual input, period. So the retina, as I said, it's kind of that pink-orange substance all around the back of the eye. The fovea is part of the retina, and then all of this visual information needs to travel from the retina and the fovea to the optic nerve into the brain to be interpreted. The point I'm making about the retina is that it's extraordinarily complex. Why am I showing all these layers? So if you were to take a cross-section through the retina, you see all these different layers of different kinds of cells with different purposes. Essentially, the point I'm making is that there are a lot of retinal cells that actually produce the dopamine precursor levodopa, which probably everyone listening to this is very familiar with that. So it's possible that you can lose levodopa and therefore dopamine in the back part of the eye, and on that basis, it can actually affect your vision. So what are some symptoms of vision loss? So if you were to lose your straight-ahead vision, trouble with driving, reading, watching TV, again, you're always focusing the center part of your vision on what you're interested in. You're unable to see fine details. You might lose contrast sensitivity, so that things like nighttime, sundown, the twilight hours, subtle shades might be particularly bothersome. You might notice glare, washed out images. And again, if you were to actually lose your visual field, which Parkinson's shouldn't do, but for whatever other reasons, if there's glaucoma as well, then with bedside and formal visual field testing, again, testing out in the peripheral vision, if this is a problem, patients might experience symptoms such as bumping into things, just not seeing in their peripheral vision, loss of peripheral vision. So what do we do? Again, we talked a little bit about what a neuro-ophthalmologist does during his or her exam. So we do check the visual acuity, distance and near with glasses. This is the near card, and you've probably seen this in the eye clinic, either for testing a distance or near, or perhaps both. So visual acuity is usually normal or very close to normal in Parkinson's. So this, again, isn't primarily responsible for the visual problems. But again, you can imagine if some of these retinal cells have dopamine, there's less dopamine, and they need that neurotransmitter, that neurochemical, to have normal vision. If you lose some of that, vision may be affected at least to some degree based on this. Usually it's a couple little things that add up to sort of the combination is what causes the visual symptoms, not necessarily just a loss of acuity, for instance. So for a Parkinson's patient, while they might do quite well with high contrast acuity like this, low contrast acuity, which isn't measured routinely, might be much more difficult, for instance. And this, again, could have to do with the paucity with levodopa and dopamine in the back part of the eye and the retina specifically. So what about color vision? So again, some of those retinal cells are responsible for color vision as well. And again, if you lose levodopa, if you lose dopamine, there might be some impairment in color vision. So how might that present? The patient might complain that colors are dull, less vibrant than they used to be. So how do we test that in the clinic? So usually color plates. So on the left are called Ishihara plates, and on the right are called HRR plates. Even if the patient's colorblind, this is something that's assessed during our evaluation. And while I wouldn't expect a severe, profound loss of color vision, again, on the basis of decrease in levodopa and dopamine in the retina and the back of the eye, perhaps this might be affected to some degree. So how do we treat acuity and color dysfunction in Parkinson's patients? Unfortunately, there's not a great treatment. Medications might help to some degree, but they're not going to totally reverse the process. Again, the same as sort of the lack of dopamine in other parts of the brain. The levodopa does a pretty good job, but it doesn't take care of everything. So again, the color vision and the acuity problems probably aren't primarily responsible for the visual issues in Parkinson's, but can certainly contribute. So we do want to make sure that other potentially treatable visual issues are addressed. So how about blinking and ocular surface abnormalities? Why is that important? So why should we care about the front part of the eye? So this would be sort of the tear film, the moist layer of tears that are on the front part of the eye or the cornea. So just from the tears being there, they give you optical clarity. They make it easier for that image of whatever you want to see to land directly on the part of the back of the eye, the fovea, where you want it to land. This tear film layer protects the eyeball itself, protects it from exposure, from dryness, from foreign objects, debris, things like that. It provides free movement of the eyeball. So if the front part of the eye was dry, there would be a lot of friction and drag on the eye, and it would be very hard to even move it. It regulates hydration. Again, its job is to sort of prevent the eyeball from drying out. And what if you do have a dry eyeball, but there's normal blinking? So again, this is something that would create friction, and over time it can actually damage the front part of the eye, the cornea. So why do we blink? So it, again, has to do with this tear film. So we're redistributing this tear film, this moist layer of tears on the front part of the eye. It redistributes it uniformly so that all parts of the front of the eye are covered. It also helps to squeeze out tears from our tear glands, which surround the eyeball itself. And blinking actually reduces significantly under certain circumstances, such as reading, computer work, driving, so that it's not uncommon that your eyes, after an extensive period of reading or computer work where you haven't been blinking so much, your eyes get very fatigued, they get dry, they get irritated, they burn, you have to blink, you have to close your eyes for a couple of seconds, you have to stop doing what you're doing. And after some period of time, when the front part of the eye is again hydrated, it's a little bit more comfortable, you can resume those activities. So there are lots of different symptoms that the front part of the eye is being irritated. So you can actually feel like the eyes are dry. You can feel like there's something in your eyes, a gritty, sandy sensation. Again, there can be just a discomfort. It can burn. There can be redness if it's irritated enough. There might be crusting on the lashes. When you wake up in the morning, the eyelids might get stuck shut. And there might be sensitivity to light as well. So these are all symptoms that are characteristic of the front part of the eye being irritated. Depending on these symptoms, seeing an eye doctor, usually they should be able to see those changes at the front part of the eye with their specialized equipment. So again, if somebody's experiencing ocular surface irritation, what kinds of questions do we want to know about? So certain dermatologic diseases, particularly those that affect the face and the eyelids, can actually exacerbate or cause ocular surface irritation. During menopause, hormonal changes can change the characteristics of the tear film and cause irritation. Certain autoimmune diseases, such as Sjogren's syndrome or lupus, might cause dryness of the mouth and or the eyes themselves. Certain medications, some that are used in Parkinson's disease, even artane, trihexane for tremor, can actually result in blurred vision and can sometimes irritate the eyes as well. You also want to know about pertinent ocular history. So what kinds of things can further irritate or exacerbate ocular surface irritation? Contact lenses. So if you're wearing contact lenses, particularly if you're wearing them for prolonged periods of time throughout the day, if you're not cleaning them as you should be, you're wearing them for longer than you should be. If you've had a history of ocular surgeries, some of these surgeries can be relevant. Allergies can certainly irritate the eyes if you have them. Eyelid trauma or surgery or facial palsy, again, these are things that on the basis of poor blinking or the inability to completely close the eyes, move one eyelid so that it's touching the top or the bottom eyelid, can result in exposure of the front part of the eye and exacerbate irritation. as well as some topical medications that can also exacerbate this. So what happens in Parkinson's? So we talked about normal ocular surface function and blinking function and why they're both important. So what happens in Parkinson's? So unfortunately, it's kind of two hits. So number one, due to whatever reason, perhaps this is some other autonomic problem associated with Parkinson's, there's poor tear production. So because the tears that are produced aren't like they should be, or they're less than there should be, the surface of the eye is irritated. And then also in Parkinson's, much like when you're reading or driving or watching TV, the blink rate, the amount of times per minute that you blink your eyes, is much reduced. So the result, again, it's kind of two hits. So you have poor tear film, you have poor blinking, so this results in dry eye and irritation. So how is this diagnosed? It's pretty easy to diagnose. Going to see an ophthalmologist, an optometrist, or a neuro-ophthalmologist. A neuro-ophthalmologist should be able to pick up this as well. Taking a good look with, again, specialized equipment at the front part of the eye, the microscope at the front part of the eye, we should see those changes that are consistent with dry eye, with irritation. And how do we treat that? Again, fairly simple. So there are artificial tears, preservative-free or preferable, using them a couple times a day if there's sort of mild to moderate, 3 to 4 times a day, and even more as needed. So, for instance, when you're reading or when you're watching TV and 3 to 4 times per day isn't doing the trick, you can use them more. Sometimes, if it's significant enough, stronger prescription medications are needed. Restasis is one of those. If there's additionally inflammation of the eyelids, which is called blepharitis, so you can see this picture at the bottom right. So there's a little bit, it's not significant, but there's some redness around the margins of the eyelids, upper and lower, and this is an inflammation of the eyelid itself. Inflammation of the eyelid is oftentimes associated with irritation of the front part of the eye, and usually they kind of exacerbate or play into one another as well. For this, hot compresses, lid scrubs, as directed by your eye doctor, can be quite effective. So essentially just good eyelid hygiene. So now we're going to talk about eye movement abnormalities. So we talked a little bit about those eye movement abnormalities that we're not going to talk about at the beginning. So things like in a patient with a Parkinson's plus syndrome with progressive supranuclear palsy, oftentimes first have the problems looking down. They might be messy eaters, and then eventually difficulty looking up, and then sort of over the course of years, potentially difficulty looking to the right and left as well. That's not seen in Parkinson's disease. So we're going to talk about these more kind of subtle findings that are common in Parkinson's. So first of all, why do the eyes move? So we talked a lot about the fovea. This is the best the best seeing part of the back of the eye. When we're reading, this is the words, the letters that you're looking at fall directly on the fovea so that you can see them well. If they fell on some other part of the retina, you would see them much less well. So the eyes are essentially there to move. So the eyes move so that the eye can reposition, so that you can direct the image of whatever you want to look at directly to the back of the eye, directly onto the fovea. So what happens if there's something up in the sky that we're looking at? Again, the eye looks up, and it stops moving when the image falls directly on the fovea. So what happens if we look down at something on the floor? It's the same thing. So the eye moves down with the sole purpose of bringing the image of that object of interest directly back to the back of the eye onto the fovea. So there are different kinds of eye movements, and actually many are affected in Parkinson's, but to a mild degree. Generally, these other eye findings are pretty subtle. Different laboratory tests and sort of formal eye movement recordings might be able to bring them out. But generally on a routine neurologic exam, you're not going to see many of these. So saccades, what are these? These are fast eye movements, and one example of when you would use a saccade is looking from one bird in the sky to another. So in Parkinson's, it's been found that that the eyes tend to undershoot the target. So as opposed to, for instance, I'm looking at my computer right now, and all of a sudden I see a bird fly by. I make a very quick eye movement towards that bird and try to find it. In Parkinson's, the eyes would actually undershoot that bird in the sky, wouldn't quite get there, so that they would need to generate a couple of smaller saccades to eventually get to the target. Smooth pursuit eye movements. So what's an example of when we would use our smooth pursuit eye movement system? So these are slow tracking eye movements. Again, if there's a bird in the sky and you're just following it with your eyes, that's an example of smooth pursuit. In Parkinson's, this isn't as smooth as it should be. It can be choppy. So it can be a series of little choppy eye movements to sort of follow whatever object you're following. And convergence, which we're going to talk more about. The ability to converge the eyes means to bring them together, so that when we're reading a book or doing something close to us, the eyes need to come together so that, again, the object falls on both of our fovea, so that we see one single image. And in Parkinson's, this is notoriously impaired. So again, what do the saccades, what do the smooth pursuit abnormalities in Parkinson's disease mean? Are they clinically relevant? Probably not significantly so. But again, if you start adding up all of these little things, over time, the combination, the contribution of one little thing could be meaningful when it's accompanied by other little findings. So again, I do want to talk about convergence because it's so common in Parkinson's. It's not entirely known why this occurs in Parkinson's. We don't have a great explanation for that, but we do know it's quite common. It's also common in some of the other Parkinson's plus syndromes like progressive supranuclear palsy. So I just want to give you first an example of normal convergence. So again, the normal action of bringing the eyes together. So on the left-hand side, let's say this is kind of across the room. We're looking at this star. So as the star comes closer and closer to us, the eyes need to sort of cross. So the eyes move in towards the nose. Again, the whole time aiming the image of the star on the back part of the eye on the fovea so that we're just seeing one single star. So what happens when convergence isn't working so well, when there's a problem bringing the eyes together effectively? So an example, again, let's say that star is across the room. It's getting closer and closer and closer. In Parkinson's, another situation in which convergence problems are extraordinarily common is a traumatic brain injury or concussion. Again, we're not entirely sure why that is, but it's just extraordinarily common. But obviously, in this case, we're going to talk about Parkinson's specifically. So let's say that somebody with Parkinson's is complaining of some double vision when they're reading, some problems with their vision when they're reading. So the closer the object comes, the harder for somebody with Parkinson's, the harder it is to keep both eyes on that target. So what would this look like? So let's say the star is coming closer and closer, and now it's quite close. So the image of the star continues to be viewed upon by one eye. In this example, the right eye, let's say we're looking down on this patient from above. Although you see that the left eye just couldn't do it anymore, it just couldn't come in anymore. The left eye sort of pops out. So now the fovea, the back part of the eye, is viewing two different images, and you see double. Because there's the convergence, the divergence problems are in the horizontal plane. The double vision experience is horizontal, meaning that the two images are side by side as opposed to vertical, one on top of the other. And so again, this convergence problem sort of exemplified by one of the eyes kind of no longer being able to cross them, and it just sort of pops out, and you experience double. So there are many symptoms suggestive of convergence insufficiency. So perhaps the most common would be this horizontal or these side-by-side double images, double vision. It can lead to headaches. It can lead to the sensation of eye strain, blurred vision. Usually this blurred vision goes away if you cover one eye. So again, if the two cameras, let's say that the two eyeballs are like cameras, so if they're looking at two different things, you're seeing two images. If you cover one of the cameras or one of the eyeballs, you should only see one thing. So that blurred vision might go away if you cover either eye. So you have the blurred vision with both eyes open. You cover the right eye, it's no longer blurred. You uncover the right eye, it's blurred again. You now cover the left eye, it's not blurred. That means that the eyes are probably just not lined up just enough so that it's a problem, but not so much that it's actually perceived as you seeing two or double image or double vision. So other symptoms include loss of place while reading, excessive tiredness. Again, covering one eye and sort of not knowing why, it's the same kind of thing. The two images just aren't lined up exactly as they should, and therefore when you cover one eye, either eye, there's some improvement. The words might seem to move on the page. You might develop a short attention span for reading, and again, a constant adjusting of the distance of a book or other to see better. So that if it's too close, you're seeing two. If it's a little farther away, it's better. So you might have to find kind of the sweet spot. So how is this diagnosed? So again, there are bedside tests where we're essentially looking for this. So we're looking for one eye to pop out. We can measure the distance at which this occurs, and that finding in conjunction with a couple other findings leads us to make the diagnosis of convergence insufficiency. It's not a difficult diagnosis to make, and generally your neurologist, ophthalmologist, or neuro-ophthalmologist should be able to make this diagnosis based on the symptoms and based on the examination itself. It's also not uncommon for somebody with Parkinson's who has some ocular surface irritation to have something called monocular double vision, where in one eye, for instance, due to dry eye or surface irritation, you might see two images. So in that case, if I was seeing two and I covered my left eye, with the right eye I still see two, that's called monocular, or in one eye, double vision. And that suggests that perhaps this is an eyeball problem, a dry eye, a cataract, a retinal problem, for instance, and that's not a neurologic problem. But it can be hard to tease the two out. And again, if you have either, I would certainly advise you to see your eye doctor. So how do we treat this? So if somebody has symptoms and exam findings consistent with convergence insufficiency, there are very simple home exercises that we call pencil push-ups. So if you take something like the tip of a pencil and you hold it at about arm's length and you slowly bring that in towards your nose, trying to keep both eyes on that pencil tip. If you do a couple repetitions, 20 repetitions or so, a couple times a day for a couple weeks or months, you might notice that your ability to converge the eyes, bring the eyes together, is improved. Again, as we get older and older, our ability to do this is affected anyway, so this might not be enough, but in some cases, if mild enough, it could be. So there is some vision therapy. There are some folks out there, usually optometrists, who do treat convergence insufficiency. Convergence insufficiency, there is evidence for in doing vision therapy. For other eye movement or eye abnormalities, there's no good vision therapy for. There's no evidence to support its use, and oftentimes vision therapy can be quite expensive, and oftentimes insurance doesn't cover it. So I would be a little hesitant to shell out hundreds of dollars for something that might not work. But again, there is good evidence for convergence insufficiency for vision therapy related to this. So if these fail, another quick fix, if you're wearing reading glasses, for instance, would be to just cover one eye, or you can even have a special pair of reading glasses where you put Scotch tape or a satin gift tape over one lens. It's essentially the same thing as covering one eye, but it lets light in, and it can be a little less conspicuous and more comfortable. Another option is to put prisms into your glasses. I would do this just into your reading glasses, not the glasses for distance, because again, there's really not much of a problem at distance. It's mainly just a near viewing or reading problem. So hallucinations can be quite common as well. And in about 25% of cases of Parkinson's, up to 25% of Parkinson's patients, generally hallucinations, visual hallucinations, are associated with daytime somnolence or insomnia, moderate to severe cognitive issues, and a longer duration of Parkinson's disease. There are certainly some medications out there that can exacerbate this. You can see in the hallucination column there that essentially any Parkinson's medication can exacerbate or cause hallucinations. So when hallucinations are experienced, you definitely need to, with your neurologist, with the prescribing doctor, sort of evaluate what you're taking and how this might be affecting them. So the biggest offenders are amantadine, as well as the dopamine agonist medications. So how do we treat this? So if the hallucinations, which are usually, I mean, they're complex, they're formed, they can be of people, of objects, of scenes, visual scenes. If they're fairly mild and the patient's insight is preserved, they know that they're not real, and they're not particularly bothered by them, reassurance is often enough. At the same time, looking at what medications the patient's on and seeing if they might be switched over to a different medication, for instance, if the patient's on amantadine or a dopamine agonist. If they're moderate to severe or quite bothersome, again, looking closely at the medications to see how they might be contributing. Some medications that are sort of best for the visual hallucinations for Parkinson's patients, although, again, these classes of medications can sometimes exacerbate the motor symptoms of Parkinson's, but these two, Seroquel and Clozaril, tend to exacerbate the motor symptoms the least, can also be considered. So some other possible ophthalmic, meaning just sort of the eyeball association. So it's thought that there might be a specific kind of cataract that's more common in Parkinson's disease, this posterior subcapsular, and primary open-angle glaucoma might also be more common in Parkinson's. It's unclear as to why this might be. But how do we diagnose and treat these? Essentially, any good dilated eye exam done by an ophthalmologist or an optometrist should be able to see this. So conclusions, take-home points, take-home messages. So there is dopamine in the visual system as well, not just other places of the brain which we're more privy to, the basal ganglia, for instance. So color vision and visual acuity might be affected to some degree. Again, this usually isn't going to be the primary issue, but as we sort of put abnormal saccades and abnormal smooth pursuit on top of this, on top of a little convergence insufficiency, it can be quite significant. So the eyelids and ocular surface protect the eye, and they optimize the clarity of what we see. And in Parkinson's, the blink rate is decreased, and the ocular surface isn't as robust and sort of protective as it should be. Convergence insufficiency, the inability to move the eyes together effectively to look at something close to us as we're reading, is a common eye movement abnormality seen in Parkinson's. And again, there are some treatments for this. There are some things that we can do. And again, the earlier these kinds of symptoms are identified, the earlier they can be addressed, the early treatment can be initiated, and quality of life improves. Thank you so much for your time.
Thank you very much, Dr. Gold. That really was terrific. I can't believe how much of it I didn't know when we started. And you've certainly raised the literacy not only among our colleagues and friends on the phone today, but also the PDF itself. We're very, very grateful for that. I'd like to start with a question about exercises. You mentioned this a couple of times, but a lot of people have written in the course of the hour asking about this. And I wonder if you could just talk a little more about what kind of exercises would be pretty standard for somebody who thinks that the Parkinson's is affecting their vision. You mentioned the convergence in particular, but is there anything further you'd like to say about this? Are there any standard exercises or sources of information on this that people should go to?
Regarding the convergence insufficiency specifically?
That and anything else you might. The questions came from all over. So if there's any other aspects of the vision syndromes that also could be improved by home exercises, if you just speak to that too.
Right. So not really. So again, the big categories, the problems with the visual acuity, with the central vision, with the color vision, again, there's not much as far as that you can do at home to improve that. That diagnosis would be made by an eye care professional. So the ocular surface problems, the blinking problems, like I said, they're characteristic features that one would see when looking at the front part of the eye that would suggest that there's dryness, whether it be mild or significant. And certainly there are a lot of good treatments out there, eye drops, things like that, some over-the-counter and some prescription. And so for the eye movement problems, again, the only therapy out there that there's any good evidence for is this convergence insufficiency. So while I said that there are some more subtle eye movement findings in Parkinson's, such as the smooth pursuit, such as the saccade problems, there's not much to be done for them. There's no evidence for any system, whether it be home exercises or doing vision therapy, for instance, that would reliably improve these. But again, there is some evidence out there for treatment of convergence insufficiency. At the very least, like I said, these home exercises, pencil push-ups as some call them, just these repetitions, again, just practicing bringing the eyes together essentially, can be helpful for some people. As we age, our ability to bring the eyes together is affected, and as we age and add Parkinson's, it's even more affected. So I wouldn't necessarily expect everyone to respond to these pencil push-ups, but again, depending on the patient's age, depending on how significant their convergence problems are, it might be helpful.
Great. Thank you very much. Question from Florida, which I'm relating to another question which of a similar nature. It has to do with floaters. And the second question was about flashes.
Okay.
And the question is, do people with Parkinson's experience more visual floaters and random flashes?
Right. So as we age, there are certain conditions of the jelly of the back of the eye, the vitreous cavity, as well as the retina itself that can lead to those kinds of symptoms. So if you're having floaters, if you're having flashes of light, the first thing that you need to do is make sure that you're not having a retinal detachment. And that's definitely not related to Parkinson's itself. It can be related to the size of your eyeball. It can be related to, if you're very nearsighted, it can be related to age itself. So those are symptoms that should definitely be evaluated by an ophthalmologist. But again, they're extraordinarily common as we age, and to my knowledge, there's no association between any retinal detachment or vitreous detachment and Parkinson's disease. But those should definitely not be ignored. But as long as you've been seen by somebody and they're not worsening, you haven't lost vision, then it's probably just benign. And unfortunately, many people have floaters, and there's not a whole lot we can do about them.
Very good. Very clear answer. Thank you very much. We have a question from the United Kingdom, a very interesting one to my eye, at least. It has to do with whether objects, for a person with Parkinson's, whether the visualization of an object can make the object appear closer than it actually is. And this person from the UK seems to think that there is a pattern here and that people with Parkinson's experience this to an unusual degree. Is that so? And any advice on that?
Right. So again, I'm not aware of any correlation between the perceived size of an object and Parkinson's disease. Again, if somebody's experiencing those kinds of symptoms, I would recommend them seeing an ophthalmologist to make sure that the fovea, that central part of the vision specifically, but the retina is intact. Sometimes if there's distortion of the back part of the eye, it can change the perceived shape or size of objects, particularly if the perceived size of an object seems different in each eye. But to my knowledge, I don't think that there's any relationship between Parkinson's and that particular symptom.
Thank you very much. Here's an interesting question from somebody who obviously has read the Brach hypothesis of the way in which Parkinson's develops over time in different parts of the body. This questioner would like to know, Dr. Gold, where in the continuum in which Parkinson's develops, from the gut going through to the brain, where might eye problems, if they exist, when might they start to be experienced in that continuum?
Right. Good question. So it kind of depends on which one. So as we said, hallucinations are associated with usually sort of moderate to severe kind of Parkinson's itself. It can be associated with sort of some of the neuropsychiatric symptoms as well. So that would imply that generally occurs later on and not so much early on. But again, certainly the medications can play a role. Convergence insufficiency, again, you're more likely to experience all of these later in the disease course, but absolutely they can be experienced earlier in the disease course. And people, as you know, have different sort of, one feature of Parkinson's might be much more prominent than another. So if somebody has a lot of hypomimia, where, for instance, there's not a lot of facial expression, they're not blinking much, perhaps their degree of ocular surface irritation might be much more than somebody else. So I think it sort of depends on the specific person, what Parkinson's has affected first, where in the disease course that person is. But of course, as we go farther and farther into the disease course, the likelihood of developing these kinds of symptoms increases.
Thank you. This next question from the state of California is sort of related to the one I just asked. And it's a person who was asking whether blurry vision or hyposmia, the loss of sense of smell, may be early indicators for Parkinson's. And the particular person raising the question reports that she, 5 years before she got the Parkinson's diagnosis, she noticed she had problems with blurry vision and she had problems with sense of smell at around the same time. So early markers of Parkinson's, how do vision problems fit into that?
Right. So again, blurry vision is a very kind of vague, non-specific symptom that can be caused by a ton of different things. So somebody might complain of blurry vision, and on eye exam it might be found that they have significant dry eye. Blurry vision could be due to a cataract, for instance. It could be due to a retinal problem, an optic nerve problem. Blurriness might be a symptom of, again, a problem, a stroke of the brain that's affecting those visual pathways. So again, I would kind of ask what is causing that blurriness, but it's such a common symptom, it's hard to relate those two without knowing what exactly that blurriness is coming from.
That's a good, fair answer. It's always a complicated one, and thank you for clarifying that. There's a bundle of questions which I'm going to try and put together from people who really want to know how to access the best medical care. Ideally, someone like you yourself, Dr. Gold, if you have your pencil and pen ready at the ready, so you can take people's names down later. We've got a person, for example, who wants to know, is it wise to get a baseline visit with a neuro-ophthalmologist in the early stages of Parkinson's? There's another person from Ohio who would like to know whether she should see a neuro-ophthalmologist rather than a regular eye doctor. You alluded to that at the very beginning of your talk, but if you could say a little more about that, I think it would be very much appreciated. And the third person from Connecticut simply wants to know, how critical is it that you find an ophthalmologist like yourself who has experience with people with Parkinson's, or is it something that, in your judgment, most competent ophthalmologist, regular eye doctor, would be able to handle? Any advice on accessing good professionals?
Right. So there aren't a lot of neuro-ophthalmologists out there, and in many communities, the ophthalmologists, more so than the neurologists, are sort of doing the job of the neuro-ophthalmologist. So there are a lot of very good ophthalmologists out there who are very aware of many of these visual issues. So I would say a baseline eye exam by a neuro-ophthalmologist, if a person's not really having any symptoms, neurologic symptoms, double vision, things like that, isn't necessary. But I think it's absolutely, again, at the very least, having sort of an annual routine eye exam. So that would sort of serve the purpose of that baseline exam, and to see if things change over time with that one eye care professional. But for the most part, ophthalmologists are very aware of these issues. Again, it's not too hard to diagnose things like ocular surface irritation, and any ophthalmologist should be able to make that diagnosis, and they do, and initiate therapy. The convergence insufficiency, perhaps some might not kind of do that part of the examination and might miss it. But again, if somebody has a suspicion for it, it's pretty easy to diagnose. Treatment can be a little bit trickier, but I would definitely start with the ophthalmologist and kind of go from there. The ophthalmologists are also very aware of what they're comfortable with and what they're not comfortable with. And if they're uncomfortable with something, they'll have a low threshold to send to a neuro-ophthalmologist. So that's generally kind of how people are referred where.
Thank you. We have several questions from people who have had various vision experiences of one kind or another and are wondering how they may be connected with Parkinson's. One from North Carolina, one from South Carolina, as a matter of fact. And the one from South Carolina, the question is about cataract surgery and what complications there may be presented in Parkinson's for somebody who has cataract surgery. And then from North Carolina, the question is about macular degeneration. And the question is it made worse by some of the medications that one uses for Parkinson's? For example, the caller mentions Elderpril and Requip. So cataract surgery and macular degeneration, very different things. Could you comment on connection with Parkinson's or Parkinson's treatments?
Right. So can you see my slides up there? I just changed the slide, the visual side effects chart or table.
I actually cannot because I'm doing it from hard copy and it's
out
of order, so I'm ready.
Sorry, hopefully the listeners can. So I just went back to the visual side effects slide that sort of outlines all the medications. So regarding the risk of macular degeneration, so there's, in some animal studies, you see the 3 dopamine agonists on the bottom have been associated with some retinal degeneration in animals. To my knowledge, they have not been associated with any macular or retinal problems in people. So that's the answer to one of the questions. And I'm sorry, cataract surgery.
Yes.
So cataracts, there may be an association between this specific kind of cataract and Parkinson's. It's sort of a less strong association, and the specific kind is the posterior subcapsular, which do tend to affect the visual acuity. But again, on any good dilated eye exam done by an eye care professional, these should be recognized. So, of course, if it's found that you have this kind of cataract and it's symptomatic, there are surgeries that can be done, and oftentimes the result is quite good. But like any surgery, there are risks, there are side effects, and this is true of any kind of patient, not just the Parkinson's patient. So I'm not sure if there are any things to look out for regarding cataract surgery from a Parkinson's disease standpoint versus not having Parkinson's. The surgery is the same, the side effects and the risks are all the same.
Very good. As you can imagine, Dr. Gold, there are several people who are now thinking about vision problems they may have and are wondering whether they are or are not connected with the Parkinson's. Here are 2. One's from New York, a person who's worried about twitching in the eye and is wondering whether that may be more common in people with Parkinson's than among everybody else. And then from Virginia, a question about eye infections, whether they are more or less likely in Parkinson's, twitching and eye infections. Any disproportionate concern for that in a person with Parkinson's? Hello? Whoops, we've lost. Hello?
Yes, I'm still here.
Sorry, good. Did you catch my question?
No, I didn't.
Okay, sorry, we'll have to try this one over if we may. These are people who have vision problems they've identified or been identified in the course of their Parkinson's, and they're wondering whether these are independent of Parkinson's or whether they may be part of the condition. One of them is twitching. Person who has twitching in the eye and wonders if that could be because of Parkinson's. The second is eye infections, and this person is wondering whether a person with Parkinson's is more or less likely to get an eye infection because of the condition.
Okay. So the first question, again, I'm trying to infer what kind of twitching they're talking about. So if there's forceful contraction, closure of both eyes, and these spasms are kind of simultaneous, that's called blepharospasm. So that is something that's treatable with Botox or one of the neurotoxins that's similar to Botox, Xeomin, for instance. Again, a neurologist, an ophthalmologist should be able to diagnose that, and not every ophthalmologist or neurologist does Botox, but most movement disorders doctors do. So if there's just a very fine twitching of one eye that's sort of not simultaneous in both eyes, and it's not forceful, it's just kind of a very high-frequency twitching. This is probably what they're describing is known as eyelid myokymia, and it's just sort of it's a physiologic response generally to poor sleep or stress or increased caffeine. It's a benign condition, assuming that the rest of the neurologic exam and cranial nerves are normal. Then, again, it should just go away over time. So again, blepharospasm, usually not associated with Parkinson's, more often associated with the Parkinson's plus syndromes. Again, an ophthalmologist or neurologist should be able to diagnose this, and Botox would be the treatment. And if it's just this benign condition, eyelid myokymia, really nothing needs to be done. Assuming everything else is normal, it should just go away over time. Regarding infections, again, aside from what we talked about, so this blepharitis, let me try to go back to that picture. Again, hopefully the listeners can see this. That was a bunch of slides ago. So as I showed that picture of the blepharitis before, the upper and the lower eyelid margin was inflamed. It was red. That's not. It's a kind of infection, inflammation. There are treatments to take care of that. Some of them are sort of antibiotic eye drops or steroid eye drops. But again, an ophthalmologist should be able to diagnose that, should be able to treat that. Aside, an eye infection specifically shouldn't be associated with Parkinson's disease, though.
Good, thank you. I think we've just time for two more questions. Dr. Gold tells us he can go a little bit long, so if that's okay.
Sure.
And I should apologize that we will not be able to cover all the questions, and maybe take a moment now just to refer you. If your question has not been answered, I'm afraid there are about 20 of you who will be in that category. If you would please use our hotline, some of you already know this very well, 1-800-457-6676. 1-800-457-6676. We have two very able professionals on the hotline, and they will be happy to take it if they are not able to answer it, because I'm sure both of them are on this call. But if they're not able to answer it from what Dr. Gold has given us, they will make sure they get the answer and get it back to you. So please use that. Okay, so the last but one question. We've got some very sophisticated people on this call, Dr. Gold. It happens every time. I sometimes think that half the people are medical professionals, but I'm never quite sure. This person knows there's a connection between vision and the freezing of a gate, as is indicated when one's using visual cues to get over a line on the floor to move through an open doorway, for example, which we're all very familiar with. I find this a fascinating question. I don't think you covered that. Could you tell us a little about what goes on there, the connection between vision and the movement part of the disorder, specifically the freezing of the gate in an open doorway? What happens with that? And if any enlightenment to give us on the connection?
Right. So myself, I'm not a Parkinson's expert. I'm not a movement disorders neurologist. But it's my understanding that it's not so much the visual cue, but any kind of cue. A tactile one, perhaps an auditory one, can have the same effect while perhaps not as robust. I'm not exactly sure. But again, I think it's just sort of a stimulation of the brain, sort of getting them out of this freezing spot. The exact mechanism, I don't know. And again, I'm not sure if this is specific to the visual system or if other, for instance, tactile or auditory cues might serve the same purpose, albeit not as strongly. I'm just not sure. Very interesting.
Actually, I'm just making a note of it to see if we can find out a bit more about this, because I think people would be interested to know if there are other ways of approaching a freezing episode than the visual piece of it. So you've given us a suggestion there, which we can follow through on. Thank you very much. The last question I've chosen here from this large pile has to do with the progression of the vision symptoms. We all know that Parkinson's is inherently a progressive disorder. Virtually everything that happens in it, whenever it happens, tends to get over time somewhat worse. And the question here is vision one of the items, along with so many other aspects of Parkinson's, that degenerate over time?
It unfortunately is. And as Parkinson's generally affects people later on in life, and as people who are later in life tend to have more visual problems in general, such as ocular surface problems, dry eyes, again, as we age, our ability to make certain eye movements, to bring the eyes together, to converge, everything suffers to some degree, independent of Parkinson's or not, just due to age. Yes, these symptoms would be expected to get worse. But again, trying to address them as early as possible, trying to initiate treatment as early as possible, much like all the other symptoms of Parkinson's, can certainly affect quality of life positively.
Thank you so much, Dr. Gold. Really, you've done us proud. If the sound systems worked both ways, you'd be hearing coast to coast and beyond the oceans a chorus of applause for this terrific talk. And I'm sure I speak with virtually all of us when I say that I learned a lot from this, and we're very, very grateful to you. I have a few business items, which those of you who are regulars on this series are familiar with. We go through this each time. The first thing is, if you there's an online survey on the screen. It should be on your screen now, I believe. Eli, is it up there now? And if you haven't already completed it, will you please do that? Your feedback does help us to improve the webinar series. I believe that it was feedback of this kind that got us the vision decision on today's talk, because we found a lot of people, to our surprise, as a matter of fact, were particularly interested in this particular area. So please do this and help yourselves and your colleagues and us by that process. I'd like to repeat my thanks in behalf of us all to the AbbVie company for the grant that made this year's 6-part series possible. Thank you, AbbVie, and we appreciate very much your several years of support of this program. Speaking of the series, I want to pitch the next one, which is the 5th in the series, I think. It's going to be on, I think it's the 5th. It'll be Tuesday, April 28th. They're always on Tuesdays. They're always at 1 o'clock Eastern U.S. time. And this one will be Tuesday, April 28th. The subject will be maximizing PD medications, how to get the most out of your treatment plan. And our speaker will be Dr. Connie Maris, who is an associate professor of neurology at the University of Toronto in the Morton and Gloria Shulman Movement Disorder Center. She's also, I'm proud to say, one of the first 2 postgraduate fellows that Parkinson's Disease Foundation funded through the Parkinson Study Group about 12 years ago, maybe even longer. But she's a great expert and a terrific friend of the Parkinson community. And I think if you've enjoyed Dr. Gold's talk and the ones before it, I think you'll certainly enjoy hers also. So please tune in Tuesday, April 28th. For today's talk, I'm informed that an archive of the event will be available starting 1 week from now, Tuesday, March 10. You go to our website, www.pdf.org, www.pdf.org, and we'll send you an email, because we have your email address because you signed up for this. We'll send all of you an email with the link when it's available so you can listen to the talk again, or maybe even suggest it to your friends or family who might be interested in this. So it just remains for me to thank Dr. Gold once more for that wonderful and very original talk. We're very grateful to him. We're delighted that so many of you came to hear him and see his slides. And we'll hope to see most of you again on April 28th. Dr. Gold, thank you so much for treating us so well. We had a great time, and it was important to all of us, and you made a great presentation. Thank you.
Thank you. My pleasure.